Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening to everybody. I would like to thank all of you, especially the organizers, for inviting me for such a lovely and exciting presentation for me. It talks about a very, very frequently found complex diagnosis. It is related to pain in the head and neck region area. I really cannot separate the head from the neck. Why? Because the neck starts at the ears. Why? Because the migraine always combine the neck and head together, including the balance system, including the sinuses, including the trigeminal component, and including the peripheral, because the central nervous system and the peripheral nervous system are all connected. Spine and spinal cord and nerves are all connected together. So when somebody asks me to define what's a cervicogenic pain and neck-related pain or neck-related pain with headache, the only thing that always comes to my mind is the cervicogenic pain is usually initially a unilateral that may centralize to become a bilateral. Usually by the time we know about it, it has already conified, became a conic, became daily, with a mixed component of flavors of little bit of a nerve, peripheral and central, trigeminal, and centralized with other intracranial component. There is a peripheral, musculoskeletal, and cranial muscular component. There is a nerve-related peptide component that is part of the nerve-related ignitation that ignite the inflammatory component that trigger the vascular to throb. And this is where we see a mixed picture of a migraine-like, a headache-like, and neck-like related entities. The neurogenic here, peripheral and central, mix together and form an orchestra of music. This is a mixed music that is sometimes triggered by any of these components, including the neck structures, including the bony structures in the neck, which are the cervical facets. And with that kind of nerve-like pulsation and peptide pooling and inflammatory component, there will be a muscular spasmodic entity that looks sometimes very dramatic to a point would look even like a dystonic-like, rigid-like muscular quality. If we look at this picture and look at the trigeminal, with the trigeminal ganglion and the trigeminal nucleus caudalis that intermingled with the greater occipital nerve complex and all together combine this neurogenic peptide in the mixture between the brainstem and the cortex and the excitable cortex and the dysregulated, dysmodulated brainstem and the role of a greater occipital nerve complex that is formed by cervical nerves 2 and 3, which connect basically the neck in migraine as well as in neck-related headache together. And once I ignite nerves, I will create inflammation. inflammation will ignite blood vessels and vascular supply and create a lot of aura-like pictures, sinuses like congestion, dizziness like picture between brainstem, inner ear, and cerebellum, and neck and head, and generalized sensitization that comes together to create a symptoms that drive us to a cervicogenic neck-related. On the other hand, this is a secondary headache, and it's an underlying a migraine that has a structural problem in the head and neck area. Again, this is how I see a migraine usually. This is how a migraine transforms. If there is a peripheral stimuli that comes from a different sources of visual and other sensory and cervical and other stimuli to work in this axis of hyper-excitable cortex and dysregulated brainstem area, where I have a centralized migraine that includes the different areas of the brain, including the cerebellum brainstem and the vascular entity, inflammation and nerve peptide and electrical waves all dance together, creating a weird related migraine inflammatory cervical component that has all the entities of a migraine that could look like a vestibular migraine with the dizziness and vertigo and the others. There's a vascular component into it, and there's a structural component coming from the neck. There is a unilateral that look like a migraine, yet it is cervicogenic, and there is tinnitus in the ear that also come to the picture. There is an exaggerated vertigo as well as dizziness component that all come together to make you look and think of a neck in this kind of exciting form of contest. Here the migraine change with time to have the neck transform it beside the medication that being used as sedatives, as anti-inflammatories, as analgesic, and other kind of treatment to address the different sources of active stimulation through sensory, visual, olfactory, or cervical entity. When we want to evaluate and take a history with that, we need to know how to ask. Of course, the usual clinical history taken. When did it start? How did it start? What caused it? Is it a trauma, a car accident, a fall, an athlete-like related component in younger age or later on? Is it job related? Is it position related? Is it a combination of osteoporosis-like, scoliosis-like, deformity-like, structure-like changes? And what is the severity of the pain? How much is it acute? How much is it subacute? How much is it a chronic with subacute and some acute inflammatory component that add into it and increase it and change its characteristic and accompanying symptoms? Is there any other symptoms beside that head pain with this headache and other neck-related component? The other thing that you need to ask is when and how do you get this kind of headache or neck-related pain? What medications are you using? How are the medication being used? How often they're used? What kind of combination? How many tablets of paracetamol? How many pills of an anti-inflammatory or ibuprofen or mixed with codeine and other muscle relaxants and opiates and other, and what's your family baseline history? How much migraine in your family? How much scoliosis in your family? How much other muscular trauma in your family? Is there any underlying component that add what's triggering these kind of symptoms and where it's coming from? How do you localize it? And on which side of the head do you localize it? And when you start looking into chronicity and the chronification, then you would ask how and when the change in headache pattern has occurred and how these changes came together and how much disability did that create on you and what is your comorbid condition. Do you have an underlying vascular stroke-like symptoms, younger in age, rigidity, MS-like rigidity, other autoimmune inflammatory, and other entity that makes it changes inflammation in the nerves, muscles, and facet joints of the neck that make this a source to create other peptide-like, inflammatory-like source of stimulation to the rest. Once we are taking the history, we start doing the exam, looking at the symmetry that we learned in neurology, how to look for asymmetrical changes within the symmetrical body. Look at the skeletal structures, the spinous process, and where it's located. Cervical is relation to thoracic spine and how the facet intermingle and how the spine goes and how many rotation and curving do I have and where the shoulder come from the rest of the neck and muscles and how is that all creating a muscular spasmodic nerve-related inflammatory component. Just remember that all of the neck and shoulder and head, spine, brainstem, cerebellum, and cortex all work together. And the scalp, how much allodynia in the scalp? How much pain in the occipital region? How much frontalis muscle spasmodic changes and periorbital, retroorbital, supraorbital, muscular spasmodic changes and inflammatory conjunctival changes that's happening in this component. I need to look at my spine in relation to a shoulder and remember the cervical distribution that comes from the cervical neck or cervical spine and distribute to the other. And then the C2 and 3 are connected and creating the greater and lesser occipital nerve, which connects the skull, which intermingle with the rest, or to the brainstem and cerebellum and trigeminal muscles, nerve, spine, neck, ears, shoulders, cerebellum, brainstem. Our primary headache always have a component of attention type headache that intermingle with the cervicogenic component and could have a migraine component that end up with a cervical entity up to the upper extremity, and that shows us that all this connection, which is inflammatory and neurogenic, and yet with time neuropathic changes are happening. Sometime I would have a cluster headache with a cervical component, a cervicogenic component triggering more of a cluster, or triggering more of a migraine, or triggering more of a tension, or a tension accompanied by neck pain and headache. How do I separate that? How do I separate a neck-related cervicogenic headache from a hemicrania continua, paroxysmal or chronic, or from the other entities of headache that would all mix together at one point? How do I separate the diagnosis? How do I evaluate? I will always come back and look at the structure of the brain and the connection to the brainstem and the cerebellum and the V1, V2, and V3 components, and it's all connection together. Remember the clinical exam. Remember how I look at the neck and shoulder and the TMJ and see how the connection of all these different branches come together with the connection to the occipital nerve, and how do I see the changes when I look at the eye in a migraine with the changes around the eye and the changes in the other entity. I would always take our vitals and evaluate our eyes and ears and look at all different components, yet I'm gonna make sure that I'm thinking of all of these entities and separating all of them together. The neck is inside the skull. The neck is close enough to the inner ear cerebellum and is connected with the rest of the trigeminal nucleus complex. When I look at head and neck and shoulder and spine, I look at a complete set of entities that comes all together and intermingle and supplied by a nerve chain that's connected to the spinal cord, connected to the brainstem, cerebellum, and the rest of the cortex of the brain, and the regulation, dysregulations, and others. When I do my cervical examination and do the evaluation, I will be looking at the all different branches of the trigeminal and its connection to the neck and connection to the other, and look at what and how much of a portion of neck in these symptoms. I have to remember that the trigeminal nerve, which is a big player in the entity of headache and migraine, is a nerve that's connected to its trigeminal nucleus, caudalis, and nucleus symptoms, and connected to the occipital in a way or another. Any inflammatory changes that is recurrent will change the neurogenic component into a neuropathic component. I will have a persistent overstimulation of the sensory components. I will feel allergenic and I will feel pain more than I should be feeling it. And look at this connection between the greater, lesser, and how well the pain is appreciated and how are the symptoms. Look at the neck and the spread of the spine of the spinal cord and the nerve roots and its connection with the ears and connection to the cerebellum, brainstem, and other. Look how a migraine would spread in the trigeminal system and its connection. Look at the nucleus caudalis, look at the trigeminal ganglion and its connection to the rest of the brain, and how the split happened through the dorsal root ganglion, and you could see the combination. This is where a trigger coming from trapezius is affecting and causing a headache, migraine-like picture, occipital originated component. This is how a sternal division, sternocleidomastoid muscle would show changes that's relevant or look like a migraine and how the spread is. All of this tells you that there is a common neurogenic supply together. There is a common muscular supply, and there is an interconnection between all of them, where when I trigger one part, the other part will react in different entities. And that makes the cervical pain, cervical headache, a very straightforward secondary headache that we need to look at and look its relation to trauma and others. We always need to evaluate in a presentation what is the source of this headache that, or neck related pain that we're having? How much is coming from the nerve? How much is coming from the joints, from the nociceptive component? How much is mixed? What is the role of post-herpetic neuralgia in the past and its connection to the other neurogenic neuropathic component, trigeminal neuralgia? And is that a fully loaded trigeminal neuralgia or a reactive component that is seen with a migraine, chronic migraine, and a cervical component, the neck pain with the cervical, and the other, how I separate and how I diagnose. C2 and C3 and up cause headache, below is going to cause radicular, scoliotic, spine rotated component will create changes, will create muscular triggers, and will create a lot of ground to create neck-related headache and others. Whenever I think of a connection between the neck and the brain, I think of a brain who's the boss who will inhibit and a cervical spine that will try to trigger inflammation and rule against the decision of the brain. And this is where the signal coming from the neck is usually inflammatory, facilitation-like, and the signal coming from the cortex is inhibitory. So basically, I always go back to history and link neck-related headache to a migraine. And remember, the migraine end up with a cervicogenic component and the role of a neck-related component in a migraine. So when I want to diagnose a headache or a migraine, I want to always want to separate and see this is episodic or chronic, and is it a new daily persistent or chronic with exacerbation, separated from a hemicrania continual like of to a cervicogenic life, and look at the entity of attention into it. And remember, most of these episodes become chronic. And what is the diagnosis for chronic migraine with cervicogenic and others? Whenever I have a chronicity, I have dysregulations between the cortex, which is hyper excitable, and the biology of the brain stem. The fundamental biology of attacks in episodic and chronic migraine is similar and involves sensitization of nerves at peripheral and central. Remember, always there's a dysfunctional brainstem, hyper excitable cortex, and remember the dysmodulated brain, the hyper excitable brain that's becoming central disinhibition, release of pain-enhancing CGRP, the role of a peripheral sensitization happening with the neck-related, and the activation of trigeminal nucleus caudalis and activation of cortical pain center via thalamus centralization. Remember that with cervicogenic pain, headache, migraine, I always have centralization. I always have a lot of inflammatory component going on. I always have trigeminal cervical complex entity. There is an increased descending facilitation or impaired descending inhibition of nociceptive processing in what's called trigeminal cervical complex. Peripheral and central sensitization come together and the head become triggered immediately by worry, including the neck, and the pain in the neck become pain in the brain, and our centralized migraine headache become an entity because of the continuous added on inflammation that's happening with recurrent stimuli. That brings us to diagnose by evaluating the brain, the neck, and do the required neck or cervical dynamic X-ray, and with it, a whole thoracic spine or dorsal spine picture to look for scoliosis and evaluate the facet, inflammatory facet, the muscular component, the spasmodic component, and other entity, and evaluate how we're going to treat it by doing the pain modulated procedures that address this entity, including muscle, including nerve, including medication that work with it, and other entities, including physical therapy and others. All of these entities and measure make us look on what kind of procedure we're going to go ahead with when we treat after we diagnose. Are we going to block the facet? Are we going to do radio frequency? Are we going to, do we have a disc disease? And we need to address that with injection that evaluate the nerve, facet related, muscular related component, and do I have a major muscular entity that I want to address it with botulinum toxin? Look at my trigger point and inject them because they are ongoing continuous stimuli. And remember, whenever I have a headache or a migraine, that I want to put a pathway of diagnosing and managing up to treatment. I have to diagnose, is that a headache or a migraine? And how much impact it has, and educate the patient of why I have to diagnose it in the right way, and get from him, her, usually her, the right history to get all the symptoms together, headache, migraine-like, vestibular component, dizzy-like, vertigo-like, tinnitus-like, neck-related-like, add on radiculopathy-like minus or only head-related component with headache, migraine-like component. And take every case as an individual management and to hear specifically about this entity. This is exactly what I'm gonna do when I wanna diagnose a pain-related, neck-related region, headache-related, neck-related, cervicogenic pain, headache, assess it, and put the plan for a multidisciplinary care that will lead us to success and happiness for the patient and for the team. I would like to thank you again for allowing me to address this very interesting subject, and I will be open to your questions whenever the time allows. Thank you very much.